Good evening, everyone. It is my pleasure to be here with you tonight for our updates from ESMO Breast 2023 presentation. My name is Dr. Naomi Dempsey. I am a breast medical oncologist at the Miami Cancer Institute, part of Baptist Health South Florida. And I'm very pleased to be joined by the rest of my panel tonight. So Dr. Jones, will you introduce yourself, please?
Yeah, my name is Dr. Jade Jones. I am a breast medical oncologist at Emory and also do health disparity research.
Wonderful. Dr. Mamounas.
Hi, Terry Mamounas, breast surgical oncologist. I work at Orlando Health Cancer Institute and also work with the NRG Oncology Breast Committee.
Welcome. Dr. Zeidan.
Hi, good evening. My name is Youssef Zeidan. I'm a radiation oncologist at Lynn Cancer Institute, part of Baptist Health.
Wonderful. Dr. Magliocco.
Hi, I'm Dr. Tony Magliocco. I'm a pathologist, a molecular pathologist and geneticist. I am a pathologist at Proteanbiodx in Orlando.
Welcome. And Debbie Denardi.
Good afternoon. My name is Debbie. I'm a patient and patient advocate. I was diagnosed with triple-negative breast cancer, and also I carry a mutation that is a BRCA1 mutation, so that's why I advocate for our community. Thank you.
Wonderful to have you. All right, so we are going to go ahead and start our conversation tonight about all of the exciting data that we saw at ESMO Breast 2023. All right. So there were a number of areas where we saw really exciting data. One area that I think we can all agree is really exciting in breast cancer right now is antibody drug conjugates and all the different ways that we can use them. We're going to be talking about how we integrate the patient voice into clinical research and how important patient-reported outcomes are, which we saw a lot of at ESMO Breast this year. We're going to give some radiation oncology updates. We're going to talk about endocrine therapy in the post-CDK4/6 inhibitor setting, the use of biomarkers and novel assays, understanding the role of immunotherapy in breast cancer, and a special focus on all the ways in which we can be increasing diversity in breast cancer clinical trials. So we're going to start with antibody drug conjugates. And this is something that we've all been really excited about over the last few years as we've been seeing the results of all the Destiny Breast trials, which have brought trastuzumab deruxtecan to the forefront, first in kind of a later line setting for HER2 positive breast cancer with Destiny Breast 02, then with in the second line setting, establishing trastuzumab deruxtecan as our standard of care in the second line for metastatic HER2 positive breast cancer. And more recently with Destiny Breast 04, looking at patients with HER2 low breast cancer and seeing great benefits for these patients across the spectrum of these trials. So I want to start by asking Dr. Magliocco to talk to us a little bit about HER2 low and some of those challenges from the pathology perspective.
Yeah, thanks. Some great advances in HER2 biology over the last number of years. Back in the day, we considered HER2 to be positive when it was amplified and highly expressed. So we had a immunohistochemistry stain for it, and pathologists would examine it, classify it as 2+, and if it was amplified, then it would be 3+ amplified, and these were considered positive cases. With the development of the antibody drug conjugates, it's clear that there's a new category of HER2, the HER2 low, that may be responsive to these antibody drug conjugates. It's actually making a challenge for pathologists. So these are the 2+ that are not amplified, that these are considered in the low category, and even the 1+ as well may be categorized as HER2 low. There are some abstracts that were presented at ESMO showing that pathologists have difficulty classifying HER2 low using current immunohistochemical methods. And this is an area that pathology is trying to develop increasing assays for. So there is a new assay from Roche tissue for HER2 low that's been calibrated and FDA cleared that can help identify these HER2 low categories. And also there's the new HER2 DX gene signature, which is a newly emergent gene signature that can help identify groups of patients with HER2 positivity that can fall into different prognostic and predictive categories. This is new on the scene. We're starting to learn how it might be useful. It's similar to the Oncotype DX. However, it's focused on HER2 biology, and it has actually multiple gene pathways in it. So it's a very intriguing signature, but it's early now, and it's I think we're still waiting for more data to be come forward on its use.
It's really exciting to have some new assays. I recently heard a pathologist refer to HER2 IHC for HER2 low being like a scale that you use to weigh semi-trucks and then using that scale to try to weigh toothpicks.
No, exactly. Because in the case where HER2 is an interesting biomarker, when it gets 3+, it's actually goes up over 200-fold. So we stumbled about it back in the late 80s. Dennis Lehman and the other work there is really extraordinary. But in those groups of cancers, it's very, very highly overexpressed and easy to detect. But now when we're looking at these more subtle changes, you're right, it's hard to detect those with those brute force. And we need a more refined ability to measure HER2 going forward. And I think we're starting to see some progress there.
Absolutely. Dr. Jones, what do you think about, HER2 low as a biomarker? Because we've got now some data from the DAISY trial as well that makes us think, maybe there is a broad range of patients that'll respond to trastuzumab deruxtecan.
Yeah, I'm actually and I think we all were excited. I think last year at ASCO when they presented the Destiny-4 trial, we got a standing ovation because, hormone receptor positive compared to our standard of care chemotherapies. And as you'll present later, when women progress on CDK4/6 inhibitors, the prognosis after that, their life is really shortened after we're getting this really good response in upfront therapy. And so the response in HER2 and the hormone receptor positive, I was also very excited to see it in the triple negatives because those are often the patients where, the average lifespan is 18 months. So being able to have another drug to offer our triple negative breast cancer patients. And so I was very interested in, as Dr. Magliocco just said, is what they said even at San Antonio, just as they said at ESMO, is, they showed that graph of pathologists being able to tell 0 from 1, and it was such a large variety. And it makes me, interested in, like if somebody's HER2 0 should, and I don't do this yet, but like, should we be giving those patients in HER2 just because of the fact that there's such a wide variety in HER2 0 and 1, the pathologist being able to determine that. And I guess I have another question for Dr. Magliocco is, in terms of like, do you think that PCR will be helpful? So like, being able to determine, we know what HER2 negative is when they are FISH, IHC2+, but is there going to be like a marker where we can use PCR for HER2 1 compared to HER2 0? So do you think that's something that will be able to help us on the molecular level outside of just a pathologist subjectively looking under the microscope?
Yeah, we hope there will be a more objective measure because there's also issues with preparation of the tissue. So if the tissue isn't properly fixed and managed, you may lose the antigenicity, so that's a problem. The way the stain is run is difficult, and then also a human can have difficulty interpreting zeros and ones. I'm not sure if a molecular, but it's quite possible a molecular assay could come along. They sometimes have their own problems in that you have to make sure you sample the tissue correctly as well, and that the assay is properly calibrated. What we might also see in the future is digital path and AI, which is really coming on, and using digital tools can accurately quantify the amount of protein that's present in a tissue sample, possibly calibrate it. And we're really seeing an explosion of digital pathology and artificial intelligence really helping pathologists interpret some of these challenging biomarkers. These stains were never really meant to be quantitative, and they're not linear. So we're really seeing where they're limited now. And I think in the future, we do need to see some different technologies because it's so important that we distinguish the different response groups.
Thank you. So we know that T-DXd has excellent efficacy both in HER2 positive and HER2 low breast cancer. When we're looking across the Destiny Breast 2 through 4 trials on the left, big progression-free survival benefits with hazard ratios in this 0.3 to 0.5 range, and OS benefits as well. You're seeing Destiny Breast 03, the overall survival not reached, but still fewer overall survival events in the T-DXd arm, and the rest of the trials with a clear overall survival benefit. So exciting data. And what we're going to be focusing on from ESMO Breast is more in regards to toxicity. And here you see a comparison, and shout out to Dr. Hamilton for her wonderful slides, and thank you for allowing me to use some of these tonight. Looking at the pink and orange bar in each of these graphs is T-DXd, and then the blue bars are their comparator arms in Destiny Breast 2 through 4. And really seeing nausea being a big issue with T-DXd, but I would just remind you that a lot of these trials didn't mandate antiemetic prophylaxis. And in my practice, either double or I tend to use triple antiemetic prophylaxis really makes a big difference in terms of how patients do. Dr. Jones, what are you doing to prophylax your patients for nausea with T-DXd?
Yeah, I think I'm similarly doing the same things that you are doing, that making sure they're going home with anti-nausea medications and adding, at least one pre-med to their to the plan to make sure, and escalating that based on the patient's response. I definitely think things happen in community practice that don't happen in clinical trials. So we will talk about some of the other side effects, but I agree with you that being a little bit more preventative when initiating these anti-nausea medications can make the patient experience overall better.
Right. Some of the side effects that we think about as being, low grade and not really dangerous, such as fatigue and alopecia, can really impact patients' quality of life. And Debbie, I was hoping maybe you could speak to us a little about the impact of side effects such as fatigue and alopecia from the patient experience.
Thank you very much for allowing me to share our experience. Really, that is extremely important because all the physical limitations, all the mental and emotional limitations make the life of the patient that is going to be limited, and it really makes a big difference. So recording all this and just taking all the precautionary steps in order for them, for us not to feel that is really very important. That's why I wanted to share some of the conversations that they had on how to work together between patients and researchers, just bringing the patient voice, that really this is reflecting the patient voice. So would you like me to go over those findings?
Sure.
Okay, so I selected this presentation because it's called Bringing the Patient Voice to Cancer Research. And within these presentations, there were 2 patient advocates with metastatic breast cancer from the US. There was a patient with an advocate also with metastatic cancer from Spain. Another presenter was a breast cancer researcher from Pittsburgh in Pennsylvania, and the other one, a clinician and researcher from Barcelona, Spain. And they all agree that really this interaction, the way that research is going right now is different, because traditionally research was done in the lab without the patient interaction. So there was a group of patients that they started interacting with these researchers at these conferences, as you mentioned, ASCO, ESMO, and San Antonio Breast Cancer Symposium, where they started just talking with the researchers during poster sessions. And they started discussing this learning process that they call it a bidirectional learning process between cancer patients and researchers. And they both were really learning from each other. Patients were learning about what researchers are doing, and researchers are learning on the patient experience, as you asked me about the patient experience. And there are many benefits of working together. For researchers, that it gives them meaning and purpose when they are researching in the lab. It also puts a human face to this cancer research. It inspires also early cancer researchers, and it makes this research more impactful and more fundable, because as we know now, all the different grants are requiring a patient advocate to write a letter of support for that particular research. And for patients, the advantages or benefits is that patients, it gives us meaning and purpose. It gives us hope for living longer and better. It gives patients a seat at the table, and also it allows us to give input and feedback for clinical trials. But there was some miscommunication between these two groups, researchers and patient advocates. So because really researchers, they do not know how to talk with patients. They didn't know. Now we are working together. And patients, we didn't know how to approach a researcher, how to ask them to participate. So they created a program that is called GRASP, that this program is guiding researchers and advocates to scientific partnerships. So during these sessions, there were small meetings between researchers and clinicians and patient advocates, and learning from each other, they were able to design better research. So the reasons for this is to improve patient outcomes, that is what we all want. For researchers, they got a better understanding of the patient needs. Also, it enhanced the research quality. It increase the engagement between and participation between patients and researchers. One thing that I found that is really interesting in this is that it increased the trust, transparency, and communication. As you know, for patients, it's really difficult sometimes to trust a clinical trial. So this type of programs is increasing that. Also, it improves the treatments and decreases toxicity because we report all the side effects. It also empowers patients, and also it improves inclusion and diversity that you mentioned that it was addressing during this conference. So this interaction, how is it done? We have small groups. They have small groups of scientists, that it could be a clinician, a researcher, a poster author, and some patient advocates, where they talk and they review the poster so we can learn more about the research, and also the researchers can understand what is important for a patient. So what I was reading from the presentations is that researchers, they mentioned after this interaction that sometimes it was the first time that they were talking with a patient. And for patients, it was really important because they were intimidated by talking with these researchers because they didn't know what to ask. So really, there were a lot of advantage from this program. So I just wanted to go over just a few conclusions that they had from these presentations, that with these type of programs, they will advance research to improve patient treatments and outcomes. They will fund more meaningful and breakthrough research that for patients, improve the quality of life for these patients, improve also the side effect management, access to research funding with patient support, improve patients' recruitment for clinical trials, specifically for diversity and inclusion, just to have representation of every type of patients. And the most important accomplishment that they mentioned is to save more lives. So that is the summary for these sessions. Thank you.
Thanks, Debbie. That's really exciting to have patients more involved in the clinical research process. I'm sure for the researchers, especially those that don't interact with patients every day, it's really motivating to see, this is what I'm doing this for. So
Exactly.
That's great. And, you mentioned that it helps us to increase diversity in clinical trials, which is a big goal for all of us, to make sure that our trials are really representing our population.
And this is accomplished specifically when you explain to patients what they're going to do, and they are not scared anymore. Because, for example, I'm Latina, and in some cases, Latinos also, they're a little scared to participate. They ask a lot of questions, so they said, no, that is not for me culturally. So that's why we are trying to train more patient advocates to teach other patients that this is something good. Participating in clinical trials and research is really important for everybody.
And Dr. Jones, I know you have a particular interest in increasing diversity in clinical trials. How do you kind of see patient advocates being involved in clinical research, helping us to increase diversity?
So I think
you're on mute.
I said, I think there's not just one reason why we have low enrollment. I think there's system issues, system barriers with the way that we design our trials. I think it is often in communities where there's fear because of prior abuse on trials. And I think, it's gaining trust with your providers, right? So they're then being offered, because I will tell you, I'm in a system where I have a large minority population, and then patients trust you and you offer them something and you explain the reasons. A lot of times they will be interested and they want to go on trial. So initially maybe a hesitancy, but I think if you gain that trust, I think patient advocacy is also important, especially when we have survivors like Mrs. Debbie Denardi, because of the fact that they've been through that. So having that personal experience of being able to explain what their cancer process was, what their diagnosis, and that education of that all around also helps. So I think patient advocacy is so important. I think being able to have patient advocates and people who take care of this community at the table when these clinical trial protocols are being created is very essential. And recently, as I've been approached by certain people of, why can't we enroll in this trial? Well, I'm trying to put it, I work at the county, Grady, our hospital, and I work at Emory. And sometimes these large sponsored trials, it's like the little things that will keep people off trial, not having a Spanish consent. That's so easy. But sometimes when the trials are so big, after they're already pushed out, it's very hard to get a sponsor to change these things. But if we can get these, patient advocates and providers who are taking care of these people in the community to sit at the table when these trials are being created, I think that it allows to make little small changes that make a large difference in this community. So I think advocates are good for just a patient interaction once, the patients are ready for trial, and advocates are good before the trials are even put out into the community, just to go over some things that may be barriers based on their personal experience, or a lot of times they're also with support groups. So they also have the experience of other women who may, and they can be, like I said, they can be an advocate for that patient.
Dr. Mamounas, what's the conversation like at the NRG surrounding increasing diversity in clinical trials? You're on mute.
Yeah, we had a lot of conversations with the Diversity and Equity and Inclusion Committee. We tried to identify root problems why some trials do not accrue. Sometimes, of course, there are issues inherent to the population that we're trying to accrue into a trial. We recently looked at one of our trials that is currently looking at randomization for patients between 50 to 70 of breast radiotherapy versus no breast radiotherapy based on oncotype scores. For patients that have low oncotype score are candidates to be randomized with T1 breast cancer. And of course, accrual to minority population is low in that trial. On the other hand, for example, we looked at some of our older trials, for example, the B51 trial, which is a trial looking at radiotherapy versus no radiotherapy for patients that convert their positive nodes to negative nodes. And very interesting in that other trial, because a lot of the patients were ER negative or triple negative or HER2 positive, we actually have an overrepresentation of African Americans in the trial. And that's because, they have more triple negative breast cancer and more aggressive tumors, which was reassuring that, potentially in a group of patients that actually need to be in that trial, they were. On the opposite side, though, in the BR007, the Deborah trial, which looks at radiotherapy, because of ER positive breast cancer and low risk patients, they may be underrepresented because some of the information suggests that, for example, the oncotype scores are higher in African American population. So we have to obviously look at and identify who is our base that we are looking for in a trial. Is our base above the average representation or is it below? And then, of course, adjust if we don't meet what we expect to meet. But of course, this is something that goes beyond, obviously, race. It has to do with other issues such as, financial, the potential for financial issues and toxicity for patients that participate in the trials. And we need to make our trials better so we don't put patients out of their comfort zone to participate in the trial. We can make them too complicated where people can afford to miss a day of work to come in for tests or do other things that the trial requires. So it's a concerted effort that we all have to make the trials able to be accessed by patients that have some inhibitory factors that potentially can contribute to them not participating. So we're taking it very, very concerted effort at NRG to actually try to address that. And we have several committees that actually looking at that.
And I just want to put, I agree with you exactly what you're saying. It's so multifactorial, but I would also like to put, because you kind of made a statement, sometimes it's just because, and I'm glad that B51 was able to kind of enroll that population. But I think if we look at the sacituzumab trials and triple negative, the phase 2, there's only 8% enrollment of African Americans in that trial. And in the phase 3, I think it was 23% in a cancer that's predominantly affecting Black women. So in that trial, most of those trials were multinational, multiple sites, New York, places where we know that Black women live. So I think that goes to show that we're not, as the NRG was really good for B51, but as a whole, we're not doing a good job. We're not doing a good job. And it's like you said, it's multifactorial. It's giving more support, it's giving better education. And like another example is, I think it's getting us into these places where these patients, and you said it's not really, sometimes it's not driven by ethnicity, it's lower socioeconomic status, but getting this place into centers where these patients are being treated. And an example, we had a study where the patient had to have infused on the same day for a trial that was specifically targeting African-American women, and that is our predominant population at Grady. But because we could not infuse on the same day, because of the way the insurance works there, and we can only infuse the day after, not on the same day they see a visit, we couldn't enroll. So I think those little things that are, when the protocols are being created, really could make, those little things logistically can also make big differences. And putting more money into extra support for women to travel, to women have to have support that they need while they're on the trial, I think also will be effective.
And this is where having a patient advocate helping to be a part of the trial design, I think, is so vital.
Yeah, and if I can add, I mean, I think another sort of trend in clinical practice in our hospitals now is to decentralize care, try to offer care closer to where the patients are. But sometimes we may not be able to offer the trials in those particular satellites where it's much easier for patients to access. So you have to put a lot more effort to actually make trials available and make the process easier to activate trials in all your satellites. It takes a tremendous effort. You don't have all these research nurses that can be in different places at the same time. So I think these are the challenges that we have to overcome. We have to make the process easier so we can then make access available wherever the patients are. And I have to bring them into the downtown facility or to, like in Atlanta, for example, into Emory to do that. You should be able to do it where they are. So I think that's an important observation.
Absolutely. Thanks
Yeah,
so much.
I had one comment also on this discussion because everybody touched on great points when it comes to currently ongoing energy trials, and especially we at radiation oncology patients, kind of when it's time for us to see those patients that have been through surgery, neoadjuvant chemotherapy. So really we're catching them at a very vulnerable kind of time point in their journey throughout the treatment. So to bring in the concept of a randomized trial is really also timing when their approach is very critical. I think here it's very important to emphasize the importance of multidisciplinary approach, because if patients go into the radiotherapy clinic with already pre-built concepts about what to expect that do not necessarily reflect the core of what a clinical trial is about, then it makes the radiation oncologist job really very difficult in order to, kind of like restart or reset the discussion from the beginning. So again, the importance of bringing clinical trials early on in the journey and introducing the concept. Let's say you have a HER2 positive patient who's at who has a 50-60% chance of converting to complete pathological response. Bringing that discussion early on about omission or de-escalation of radiation therapy is very key during the tumor board discussion. So I find that very helpful because, I've had some cases where patients essentially decline enrolling on a clinical trial, or they even don't want to discuss it further. And it turns out that the core of it is that they believe more treatment means better outcome for them, whereas the scientific data is not there. So again, re-emphasizing the timing of the discussions and the multidisciplinary approach, and the timing when they're approached with the clinical trials.
Yeah. I mean, I think you're making a very good point because particularly as you mentioned, we now have a clinical trial trying to omit radiotherapy for HER2 positive patients that have either a PCR or have a low risk tumors. But if the system is already geared to say, oh, you're going to have neoadjuvant chemotherapy, and then you're going to have radiation, and then you're going to have more antibodies, and we tell them again and again and again, and then they have to see the radiation oncologist, and they say, oh, but we have this trial. It's very foreign to the patient, so we all have to change. And that is true because several of the trials, we saw very low, such de-escalation trials, like B51, for example, we saw a very slow ramp-up accrual to the point that we thought maybe we're never going to be able to complete the trial. It took us almost 7-8 years to accrue. But then when the word spread out and we start talking to patients, they say, well, if your nodes are becoming negative, at the time of surgery, maybe you have an option to avoid the local regional radiotherapy. So I think you're right. It takes a village. We have to all be part of it, and we have to be familiar with the trials that we're offering to patients so we can start the narrative early on in the process. I think that's a great point. Naomi, you're mute. One more time.
We have a few questions here in the chat that maybe we can address before we get back to the data. So we have one question here regarding an adenoid cystic carcinoma of less than 1 centimeter on the breast biopsy, which was hormone receptor negative. And the first question is surgical. Can they get a lumpectomy or should they get a mastectomy?
No, I mean, I think adenoid carcinoma is a perfect example of somebody that could definitely have a lumpectomy. Usually presents with a small tumors. They're triple negative, but they don't necessarily have the same aggressive biology that triple negative patients have in general. So I think that such a patient with a centimeter would be a great candidate for lumpectomy and radiation afterwards. Absolutely.
Great. And they're also asking here about if we would give anything adjuvantly, Dr. Jones.
I definitely would. I think she should go to upfront surgery and get the final path and make sure it's consistent with the adeno and there's no other cancer. And I definitely think it's a tumor board discussion on these patients, because a lot of times with the adenocystics, even when you do give chemo, you don't, especially that size, not necessarily necessary. And if it was a larger adenocystic, often you don't use the typical chemos that we use for invasive ductals. They treat it more like the salivaries. But definitely I would recommend upfront surgery and reviewing the final path and a good discussion.
Excellent.
I don't know if you would be the same, Naomi, with that.
Yeah,
Yeah.
I wouldn't generally, be thinking about kind of our conventional chemotherapy for an adenoid cystic. I just don't think that they're very chemosensitive, and it would just be too much toxicity for the benefit that you probably wouldn't get. But agree with the discussion and evaluating the totality of the path. Dr. Magliocco, could you discuss how the Roche assay that you mentioned, how does it work and how is it reported, and are you using that at all?
Yeah, the Roche assay is basically a modification of the existing Roche assay. That's a HER2 immunohistochemical assay. So it's shipped out in special containers. It runs on Roche equipment. It's FDA cleared, and there's instructions how to use it. So it's basically optimized for the HER2 low. So it really isn't a lot different. So if a pathologist using the conventional IHC, this one can be easily added, and they just need to learn how to interpret it in terms of the zeros and the ones and so on. So it's a fairly straightforward assay that runs on Roche equipment.
Great.
I also included a link there if people want to look at it, so they can look at that as well.
Perfect. I think our team is sharing that out with our participants. And then it looks like as of right now, the last question that we have is, what do you think about some of the data using trilaciclib for ADC? Some of the studies showing significant improvement of side effects in phase 2. Dr. Jones, do you want to speak to that?
I'm really unsure. I saw that question. I was a little bit unsure about. I'm not sure about that data. So I don't know if Naomi, you know anything about that.
The data that I've heard about with trilaciclib is using it prior to conventional chemotherapy to try to decrease some of the side effects. I'm not aware of using it with ADCs, only kind of with I think the phase 2 study I saw was using it with CarboGem. And certainly, interested to see some phase 3 data. But I think, again, we've all kind of learned the cautionary tale of making treatment decisions based on phase 2 data, and so would await some phase 3 data before incorporating. All right, so the DESTINY-Breast02 patient reported outcomes that we got from ESMO 2023 was looking at a survey that was basically to determine time to deterioration. So looking at health-related quality of life and seeing a big improvement with TDXD compared to treatment of physician's choice, and a delay in deterioration of health-related quality of life, which is not surprising, given the superior efficacy of TDXD. And then similarly, in DESTINY-Breast04, here they used a different measurement of toxicity. They used exposure-adjusted incidence rates, which basically means that treatment emergent AEs were looked at per time period that patient was on the study drug. So it basically accounts for differences in treatment duration. And really, we see across the grade, across the scale, T-DXd performing better than treatment of physician's choice in terms of adverse events, serious adverse events, dose reductions, and dose interruptions. So although certainly there's some safety signals we're going to talk about with T-DXd, overall, it seems that they had fewer exposure-adjusted incidence rates. And Dr. Jones, maybe you can talk to us a little about what do you think about this endpoint of exposure-adjusted incidence rates as a way of looking at toxicity?
It's a little odd because it's not a common endpoint that we use on trials. And so it's a little hard for me personally to interpret this. But, overall, I just kind of, I've looked at the side effect profile and I go from, when I'm explaining to patients, just go over the risks that were more likely on the trial, not really using that term exposure adjusted incidence rates. And even though in general, the lung-related toxicities are low, I always tell patients that because those were occurrences that occurred and end up in death, like right on the first trial, the Destiny 2, there were 2 deaths. So I think this is a little bit hard to interpret. So I kind of use just the overall incidence of the graph that you showed before, because of the way, this is probably the first trial I've seen this described as an exposure adjusted. And maybe they were trying to make sure like intention to treat or how much people got dose until they were most like a dose dependent toxicity versus just which group were you in at the time in that description. So I think that's kind of maybe their way they were trying to go, looking at more of dose of how much exposure.
Yeah, I kind of thought similarly about it, that it's not easily digestible, but that if you're looking at the duration of time that patients are on T-DXd, because it works so well, so you're keeping them on it because they're getting good efficacy out of it. So if you're averaging their side effects over the total amount of time that they're on it, it kind of makes the side effects look a little bit less, as opposed to just, toxicity rates. But I do think the fact that patients are staying on it for so long because of the superior efficacy, certainly is good for quality of life when you're not progressing. And to your point about the ILD and pneumonitis that we see with T-DXd that we're all well aware of at this point, any grade in that 10 to 15% range. But certainly we've gotten better at screening for this, at treating it quickly, at, hopefully catching it when it's grade 1. And one interesting thing that they presented at ESMO Breast this year was about the patients who were retreated with T-DXd after a grade 1 ILD. So just to recap, that grade 1 ILD is when you find it on a scan, but the patient doesn't have any symptoms. And so there were 6 patients on Destiny Breast 04 who were retreated after they had grade 1 ILD. And you'll notice the kind of lighter blue bar here is treatment time with T-DXd after they've already had their ILD event. And like the bottom 3 lines here, they got a long time out of T-DXd after having already had ILD. So I think, there, and only one patient, the top one here, that had a recurrence of ILD. And so I think it just goes to show that if we can catch this early while it's still asymptomatic and ultimately retreat, that it is overall safe to retreat and that there is a lot of efficacy still to be gained during that retreatment period.
And I think it's just high vigilance. I remember at San Antonio this year when they were rediscussing this toxicity, I think the presenter mentioned that she would do a scan every 4 weeks. And I think feasibility of that is unlikely. So in general, your practice is that I'm just doing the routine scans, and then if they are having new symptoms, I'm getting chest x-rays in between. And I will say of all the patients I've given this drug, both in the HER2 hormone receptor positive and triple negative setting, I've only had 1 patient develop ILD. It was grade 1. Unfortunately, when I re-exposed her, she developed it. It went away and then it came back. So she had other good options, and not to say I'll never use it again, but she remained grade 1 when it returned. but we just kind of felt just to go ahead and for her to come off drug. So like I said, I think overall this drug for most of my patients, and I have now had patients on it for 2 years, have done overall well. And so, but just something you just have to have like a heightened sense for. But definitely, I thought the 4 week, every 4 weeks I can't get that insurance approval, and I think that's a lot for patients in terms of imaging CT chests.
I'm re-imaging after the 3rd dose, so at around 9 weeks, and that way I'm getting a sense of whether there's efficacy and also kind of screening for that ILD. But some of the data that I didn't include here was the average time to development of ILD, which we've all heard, but I think it bears repeating, that on average, it was about 4 months when patients developed ILD. And I think we all are really vigilant about this in the beginning. Like for the first month, everybody's on super high alert for ILD, but then you kind of get into this sense of comfort. And so then a few months down the road, that's really when you need to be most, have it really at the forefront of your mind. And Debbie, I'd like to ask you, is this something that patients talk about, because we all in the medical oncology community are talking so much about ILD with TDXD, and we certainly tell our patients about it, but is it something that the patients are really afraid of or talking about?
Not really for ILD, but yes, about insurance coverage. As you were saying, that really, what can we do if the recommendation is to test every 4 weeks? Why do we have to be waiting because insurance doesn't cover it? So is there something that we can be doing in order to advocate for these patients to get the right treatment at the right time for that medication, that really they should not be waiting to be tested whether or not they have these symptoms? So if you have any ideas, I will be happy to take it to, I don't know, insurance companies, our representatives. That would be fantastic.
I think it always helps.
Oh, go ahead. I was just saying that was one person. It wasn't like a guideline recommendation or a recommendation from the pharmaceutical company. It was just a panelist like myself saying, this is what I do every 4 weeks. So, and I think it may be causing more harm just not just the insurance reasons, but like not necessarily the necessity of needing frequent scans and anxiety of those scans. So, and like she said, really what's coming is like my patient developed it after 9 months. It's not something that's happening in the beginning of treatment. So I think in terms of me not ordering, it really isn't only insurance driven, it's also like patient driven, just the anxiety of having, every time I order a restage and scan for a patient, that's anxiety provoking. Is my cancer back? Is it, sometimes patients like to go like intervals where they're not having to worry about their cancer all the time in terms of the restaging, and they clinically feel well.
Thank you for the clarification.
Having guidelines is helpful both for clinicians and for getting approvals. So, as we kind of come to understand this better and create guidelines surrounding how we screen and manage, I think that's really helpful.
And Naomi, around the same point of the pneumonitis, just to kind of highlight from a radiation oncology perspective, how these novel agents are kind of changing even the way we are practicing as radiation oncologists, because it really depends where you're directing your radiation beam for such patients. A lot of times we're extra careful when patients have received such agents when we direct the radiation in an area where there will be radiation dose going to the lungs. So because the radiation on its own could cause pneumonitis, and we have these novel agents that are highly effective, but then you have this around 10% that develop this ILD. So again, it brings the challenge of safety of combination of these novel agents with radiation therapy, which we don't have much data of. So I think the next few years, as you said, guidelines, and as more data mature on the combination of these novel agents with radiation therapy, it will be very important. Until we have this data, we're extra careful with the volume of the lungs that are receiving radiation therapy as a collateral dose when we're treating our targets with radiation.
And I think as we start to think about our embarrassment of riches in breast cancer, all the different kind of tools we have in our toolbox and sequencing, if a patient gets pneumonitis from Keytruda before we have a chance to use TDXD, you're kind of concerned about the idea of starting that patient maybe later on down the road on TDXD. So I think it just, this story is coming up a lot in the hormone receptor positive space, where we're thinking, does everolimus and exemestane really have that much efficacy that it's worth exposing them to potential pneumonitis now and then maybe precluding us later from TDXD? So I think it's just really important for us to understand more about sequencing and which agents are kind of most important in our toolbox, which we're learning. All right, so next I want to talk a little bit about HER3 DXD, pertuzumab deruxtecan, which we heard some new data about at ESMO Breast this year, and is kind of an exciting up and coming antibody drug conjugate. Dr. Magliocco, could you talk to us a little bit about what is HER3 and what is its role?
Sure. HER3 is part of the member of the HER family. So that's HER1 through HER4. HER1 is also called EGFR. You may know it as EGFR. HER2, we're all very familiar with in the breast cancer world. It's been the star for a good 30 years. And interestingly, we never quite know what HER2's ligand is. It seems to self-dimerize and drive cancer. Now, HER3 is another member of that family. So it appears to cause dimers with other receptor tyrosine kinases. So it's a receptor tyrosine kinase on the surface of the cell. And like the other receptor tyrosine kinases, it causes intracellular signaling through the PIK3CA pathway down to AKT and can lead to migration and cell proliferation. So it's part of those growth factor pathways. HER3 can become overexpressed in a number of breast cancers. It's not one that's been routinely studied, so it's a new player on the stage, and it's one that pathologists are not particularly familiar with. So it's one that will require, again, additional biomarkers for analysis. And again, pathologists will need to learn about how best to evaluate it and measure it and so on. And indeed, if we do have to measure it, usually we end up having to measure it in that there is a variation in its expression. And we might expect that tumors that have high expression of it will probably respond better to therapy against it. So that makes some sense there. I don't know myself if it's amplified. I don't, it might be in a small group, but it may be overexpressed by other mechanisms. So it's a new player on the block there, and one gathering interest. So thanks for the question.
Yeah, exciting. So we do know that HER3 overexpression does portend a worse prognosis in breast cancer. So particular interest in kind of how that plays into response. So HER3 DXD is an antibody drug conjugate that in a lot of ways is kind of congruent with trastuzumab deruxtecan, except the monoclonal antibody is HER3 directed, but it has also a cleavable linker. It has the same cytotoxic payload. It has a high drug to antibody ratio, and it has bystander effect. So in a lot of ways, it's got some of the best features of trastuzumab deruxtecan. And we've seen in prior studies presented at ASCO last year that HER3 DXD is active in all breast cancer subtypes and whether or not HER3 was overexpressed. So there's particular interest in kind of understanding who are the patients who are going to respond. Because when you look at these waterfall plots, you see most patients really were, having some level of response, but we didn't have a good way thus far of selecting those patients. So the study that was presented at ESMO Breast this year was the Icarus Breast 01 study, and it was looking at patients with hormone receptor positive, HER2 negative breast cancer in the metastatic setting who were unselected for HER3 expression, so regardless of HER3 expression. And these patients were receiving HER3 DXd, and meanwhile they were undergoing whole exome sequencing and tumor tissue biopsies to try to look for markers of response. And overall, we saw the majority of patients, 53%, had stable disease. We did have some partial responses and 18% progressive disease. This trial is still ongoing, and so there will be more data coming in the future. But basically, they saw that that HER3 positive circulating tumor cells did go down with this treatment. But in terms of really identifying who are the patients who are going to respond to this therapy, I think there's more yet to come on that story with further analyses. Dr. Jones, was there anything you wanted to add about HER3 targeting?
No, I think that, that you presenting this study, and San Antonio, they talked a little bit about HER3, so I definitely think this is going to be an interesting target, and just more studies ongoing to kind of further delineate which patients really will have the most effectiveness in.
Yep, not ready for use on Monday morning, but
No,
of
not
interest
yet.
for us to keep an eye on. All right, since we're talking about biomarkers for response, changing gears here a little bit to talk about the HER2-DX assay that Dr. Magliocco referred to earlier. And this study will be looking at HER2-DX to predict pathologic complete response in early HER2 positive breast cancer. So Dr. Magliocco, you already told us a little bit earlier about what the HER2-DX assay is, but would you mind going over for us one more time what exactly this assay is?
Sure. It's one that's sort of newly arrived as well. So it's one of these gene expression assays, a gene signature. People may be familiar with Oncotype DX, which is a 21 gene signature that predicts chemotherapy response. This is a similar signature that's been developed to look at HER2 response in the neoadjuvant setting. So it's a 27 gene expression signature that's been developed by a company called Reveal Genomics and is currently available. It appears they have some evidence on it collected from analysis of about 2,000 cases and so on. I think it's still somewhat early days for this assay. So, but it's intriguing to see it make an appearance on the field. It looks like it's reported out. It's one I haven't used before. It looks like it gets a score similar to HER2, similar to Oncotype DX, that puts a tumor into a category of low, medium, and high. And this information appears to be associated with the probability of response to a neoadjuvant treatment. So it'd be interesting to hear what the oncologists think of it so far. So thank you.
So in this study, they pooled patients from 4 different neoadjuvant trials and looked at whether HER2-DX could predict PCR and kind of compared that to other ways that we have tried to predict PCR in the past. So you'll see here that there was a wide variety of nodal status, of hormone receptor status, and that really the HER2-DX PCR score groups kind of fell a third. So low meaning low chance of achieving a PCR and high meaning high chance of achieving a PCR. And when we looked in the overall population, the HER2-DX PCR did a good job of predicting who would have a pathologic complete response. And this was regardless of things like their hormone receptor status, regardless of what type of therapy they received. So it does look like this is, the assay thus far is performing well. And then when we look at patients who either received Herceptin alone, Herceptin with chemotherapy, but without pertuzumab, versus those who received dual antibody, so both Herceptin and Perjeta, in combination with chemotherapy, we see that numerically everybody, regardless of which HER2-DX PCR group they were in, everybody benefited from the addition of pertuzumab, but really those who already had a high chance of achieving a PCR got the most benefit out of addition of pertuzumab. And the idea there is that those that are already having a high chance of achieving a PCR are probably the most HER2 addicted tumors. And so adding the pertuzumab was the most benefit for them. But when they looked in the overall population, as expected, there was a benefit from on the order of 13% from addition of pertuzumab. And then when we looked at whether or not for the chemotherapy portion of the treatment, whether one chemotherapy agent versus two chemotherapy agents made a difference. And in this analysis, there was no statistically significant increase in PCR rates in the overall cohort who got multi-agent chemotherapy, but amongst those who had a medium chance of achieving a PCR, those were the patients who had the most benefit out of multi-agent chemotherapy. And the thought here is that these are somewhat less HER2 addicted tumors, and they're those who maybe have more of an immune signature and thus have more benefit from chemotherapy. So we were talking a little bit before we all got on the call tonight about, is anybody actually using this in their practice? And I know I have not been. Dr. Jones, do you use HER2-DX?
No, I have not. And I think because this is so early, it doesn't really, as you said, like if you had a low PCR, it didn't really change, but would that mean you're not going to use it? No, you're probably still going to use it because those patients are going to have more aggressive disease, and our mindset is to give more therapy to try to get them there. So, and it's kind of like the Oncotype DX. If you look at the TAILOR-X trial, that women who are high risk needed chemo, but that chemo, they still were high risk, right? So even despite chemo, their risk of recurrence is really high. So I think this is a good starter, and I anticipate in the next couple of years, we're going to start seeing trials just like the Oncotype DX trials, how they evolved, where we now try different things in the neoadjuvant setting that can change what's happening now that we're able to better molecularly profile these patients. So I personally don't think this is going to be as helpful, just because even though they were able to kind of tell you how things were going to look in terms of profiling, it's not optimal about what you should do based on that profile. Other than this is a very good description. And then someone just put, it might be helpful in our carboplatin shortage situation. That is true. That now, with the hopefully that won't last that much longer. So you maybe do TA. Right now we're basing, at least I base my treatment in the neoadjuvant based on their stage, right? Stage 1, they're probably not going to get it up front, and I'm going to do TH by itself if that's their stage on the back end. If they're like a stage 3, I'm often getting TCHP. If they're stage 2, I'm considering the COMPASS trial where we're de-escalating to just like a THP. And so that's stage based, and maybe information like this may help me further maybe put people into the TH. Let's go to upfront surgery if they have this profile, maybe a stage 2, but they're very low. But I think we need more data to definitively, outside of a carboplatin shortage, use this to guide more definitively our care.
Dr. Mamounas, do you see an assay like this being integrated into future clinical trials, and how might we be able to use that in a clinical research setting to try to determine who needs what therapy?
Yeah, I think that what I'm thinking here is similar to, again, what was discussed before about like an Oncotype DX situation where a prognostic assay is important, but even the Oncotype DX did not take off until we realized it was also predictive of chemotherapy benefit, and then we can use it to make a yes or no decision as to use chemotherapy. So this is a similar situation here. it's a yes or no decision. They say you do dual anti-HER therapy versus single anti-HER therapy, or multi-agent chemotherapy versus single agent chemotherapy. One of the issues that I wanted to always get an answer, but I'm not sure if I've gotten it yet, is whether ER status is part of this HER2-DX, because obviously in ER negative HER2 positive patients we see higher PCR rates, almost close to 80%, and for triple positives we see more in the 50%. So if these genes adjust also for ER status potentially, then you may have some of the answer being, in other words, I want to see an analysis controlling for ER status to show me that this is a in the previous, yeah, you think you showed maybe the composition. I don't know if the multivariate analysis, whether ER status, hormone receptor actually was adjusted for. Yeah, here hormone receptor negative versus positive was part of the multivariate analysis. But I think we have to also look at the genes there, because let's say if some of the genes capitulate the ER biology, then it may be that this test is better predictor because of this biology of the ER, and then the traditional ER falls out of the model because you already adjusted in the HER2-DX. So I think that's something that, but again, you have to be able to make a different clinical decision. We have a lot of prognostic, and maybe we'll talk about also like ctDNA, which is the same kind of thing. We see now that it's very prognostic in bad outcomes. However, what do you do with the information is the question, and can you change what the outcome of the patient by making a different decision? So I think these are the trials that we have to be focusing on as we go forward.
Yeah, I think we're not ready to make any changes in clinical practice based on this, but would be interested to see how it can integrate into clinical research. So we have a few questions in the chat. Let's take those. What do you think is the role of high TMB in metastatic triple negative breast cancer who is PD-L1 0? Would you offer checkpoint inhibitors? And I think I'd like to start with that question by asking Dr. Magliocco, you know, what do you think of PD-L1 as a biomarker? What do you think of TMB as a biomarker? Because I think we've struggled a little bit with the fact that PD-L1 is definitely not a perfect biomarker for immune checkpoint response.
Yeah, there's very few perfect things in the world, and these biomarkers certainly aren't. PD-L1 is a very challenging marker for pathologists. We've seen there's different ways to measure it. So there's 22C3, there's SP263, and SP142. So, and there's been different there's different cut points and so on, depending on its use. It seems like it is, we're learning more about how to measure it. So certainly in cases that have high PD-L1, they're often predictive of a checkpoint response. Now, with the tumor mutational burden, it's another imperfect marker where it's actually thought to correlate with neoantigens or other things. Again, it's an indirect measure. There's still controversy in how you exactly measure it, but we have it. It's linked to FDA clearances and so on, so it's there. It's independent of PD-L1, so so it is definitely a marker that's available. So both PD-L1 and TMB are markers that are approved. They are imperfect, and we're learning more about how to improve them over time. So I'm curious to hear what the oncologists and clinicians think of them.
Yeah, so Dr. Jones, would you treat somebody with metastatic triple negative breast cancer with high TMB with checkpoint inhibitors if they were PD-L1 0?
I definitely would. And that is just because it's personal experience doing that. I would not do it as a single agent. To be quite honest, I'd pair it just like with paclitaxel or Abraxane or carbopim, just because these triple negatives, and if you've any had these stage 4 triple negatives, they are so resistant to therapy, and they often blow through multiple therapies. And I personally have had a patient who was triple negative, and this is when atezo was approved. She got atezo and paclitaxel up front. She had 4 or 5 doses, and then had toxicity, dose limited toxicity. We had to stop, and she had a complete CR. And then eventually I put her on Xeloda, and she was NED for 2.5 years. And I always call her my miracle patient, because is such an unusual. So when I profiled her, she was tumor mutation brittle high, and I honestly believe that the reason why that she was PD-L1 positive, it was a little different, but I have a lot of PD-L1 positive patients who did not do that, and even on the trial, it was only 7 months versus 5 months of PFS before they took it off market. So I really believe that her high tumor mutational burden, just like in our lung cancer patients who high tumor mutational burden and our other cancer types, was a driver by her response. So I think because we have such limited therapies with these women that will actually be effective, I would use and it is FDA approved for high tumor mutational burden, considering adding immunotherapy, which is tolerated well in general with chemotherapy to these patients, even PD-L1. And that's just from personal experience and just knowing how outside of sacituzumab and sometimes in HER2, that most of these chemos that are giving these women are unfortunately not effective for them.
Mm-hmm. And one word about measuring TMB is that it can be overestimated in liquid biopsies. So if you're getting back your TMB of 10, you're just making the cut point, and on a liquid biopsy, it may not truly be that high if you were testing in tissue. So just a word of caution there. The next question we have is in regards to brain mets and HER2 positive breast cancer, preference for TDXD versus tucatinib based regimen, and how are we deciding between those two? So Dr. Jones, I'll let you take that.
Yeah, so I think, we have some trials where they, within HER2 that have been presented at different variants, that it actually has good penetration to the brain and can have up to 60 to 70% response in people with brain mets. So I think in HER2 is a really good option. And so I definitely have come across this where, should I use tucatinib or should I use in HER2? And now that HER2 has moved to second line, I often am moving, if I have a patient with brain mets and it's second line, I'm using HER2 over to tucatinib. And not to say tucatinib is not a good option, but a lot of times doing an infusion every 3 weeks is a lot easier than doing tucatinib and Xeloda and then Herceptin. So just in terms of ease of use, and HER2 is just better, a lot of times better for the quality of life because they're getting infused every 3 weeks. They don't have to worry about having to take multiple pills per day. And we have good data now with HER2 and brain mets. Now, if they've already progressed on, TDM1, Kadcyla, I'd be a little bit more wanting to get another, especially if they didn't spend a lot of time. So I think there's a scenario here where people have had THP, they had TDM1 because HER2 wasn't approved yet in the second line setting. And now you're on third line and you're deciding between HER2 and tucatinib. And if they didn't spend a lot of time on TDM1, which is another ADC, then I'm more likely to let me try to get a completely different target in terms of tucatinib and Xeloda and use tucatinib and Xeloda in the third line over HER2. And not to say I won't use HER2 later, it's just that both TDM1 and HER2 are ADCs, and I'm trying to maybe get a different, work a different pathway.
And, I am swayed by the CNS OS data, just because OS data kind of is our holy grail. So I tend to prefer HER2 climb in that setting, but I absolutely agree. I'm impressed by the intracranial responses with TDXD. There's an ongoing trial now with TDXD that's also enrolling patients with leptomeningeal disease, which is a big area of unmet need. So excited about that. And Dr. Zeidan, maybe you've got some comments there on how we can be integrating radiation with some of our systemic options.
Yeah, no, I think, this is an area of a great advance, and it's so rewarding to see multiple options for patients with brain mets other than radiation therapy. Sometimes the importance of multidisciplinary discussions about these patients and routing them, which patients are symptomatic that need, so I think a couple of factors are important to consider in choosing whether these patients are better served with radiation therapy first or systemic therapy first. Some of the deciding factors is symptoms, the location of the metastases, and the volume how much metastasis is present on the brain MRI. So it's an evolving topic, and hopefully we will have in the future randomized data in order to guide which ones are first. But for now, as radiation oncology, we are prioritizing patients that are symptomatic, edema or compression effects for kind of routing them to radiation first.
Great. And so Dr. Zeidan, I'm going to ask you to talk about some of the updates in radiation oncology next.
Yeah, thank you. So there were a couple of interesting abstracts that were presented at ESMO Breast this year. I highlighted them in a couple of slides. The first one is an interesting study that came out of McMaster University in Ontario, Canada. This is a study that looked at adjuvant radiation therapy in breast cancer patients, depending whether or not they are residents of Ontario or they are immigrants. So this is a retrospective study, looked at patients with stage 1 to 3, treated in Ontario, Canada between 2010 and 2016. They had a fairly decent number of patients, as one would expect. It's a big population that lives in Ontario. So 54,000 total patients were studied. Most of them were Canadian or long-term residents, 86%, and 13% were immigrants. So they basically looked at two things. They looked at the odds of receiving radiation therapy after lumpectomy, and also the time from surgery to radiation. So overall, they found that immigrants have a longer duration of wait between surgery and getting to radiation therapy, on average about 10 days or so. I do have to highlight here that as compared to the US, these numbers look definitely higher, and probably has to relate with the Canadian healthcare system as compared to the US healthcare system. Definitely where I practice, the average wait time from lumpectomy to radiation beam on is no more than 60 days. So many times even shorter than that, sometimes within 6 weeks where patients are receiving radiation. So these numbers are a little bit on the higher side. The other point to highlight here is if you look at the map on the right-hand side, it kind of like gives you this idea of depending on where these immigrant patients are from and the wait time to starting radiation therapy. So you could see the areas that are highlighted in the darker colors, such as patients that are immigrants from African countries or immigrants from Latin American countries. These tend to have the longest wait times, up to 134 days between surgery and starting radiation. And these numbers are worrisome because once we kind of bypass this 3 months time point, we start worrying about early recurrences, especially for patients that are at high risk. So definitely these numbers are alerting. The other important finding of the study is the odds of receiving radiation therapy after breast conservation. So around 14% lower in immigrants compared to Canadian citizens or residents. So again, it's a point to stop at, especially at a day and age where our technology is improving. If we don't have this technology accessible for patients, then this is something we have to improve in the future. So they concluded there is a lower proportion of immigrant women receiving radiation therapy after breast conservation, and that immigrant patients have longer wait times. So again, I think this kind of theme can be stretched across not only radiation therapy perhaps, but also some of these novel targets. We really have to make sure that our technologies and our newer therapies are accessible to all patients. I don't know if Dr. Jones wants to comment on that, since I know it's an area of research interest.
Yeah, I mean, I think definitely agree, and I wonder because the Canadian healthcare system is a united healthcare system, and I wonder if the process of getting access in terms of all these immigrants who have been there, like they're multi-generation immigrants, and is these people are people who came into the system after, and so is it the process of getting them, like, is there a delay because of how their insurance is cared for compared to someone who was born there? I mean, there really shouldn't be, right? We should treat all our patients, but I wonder, they definitely need a study to figure out, like, why was there this delay? Is it a language delay? Is it based on their enrollment into the care system? It's very, I mean, we have our own issues even in our patients over here, right? Unfortunately, you would think that because they are a united healthcare system, a care for all, that they wouldn't have that delay. So it's very interesting that immigrants are delayed. And I think this is a universal problem. Even at the ESMO, they presented an abstract that showed that within European clinical trials, there was very low representation of their underrepresented minorities, right? So this is not like a national issue, it's an international issue amongst different healthcare systems. So it's a very interesting concept, and just kind of interested in terms of like why they could pinpoint why, or at least hypothesize why that delay is occurring specifically in this immigrant population.
Yeah, it's sort of interesting just to jump in there because I'm in Canada right now and I'm a Canadian as well, that the US immigrants are delayed there, and there's even from the UK. So it's interesting, the pattern here where the Russians and Middle Eastern ones seem to be getting access earlier as well. So very intriguing data for sure. And this is pre-COVID. I see this is pre-COVID data as well. So interesting.
We are starting to run short on time here. Want to get to a couple more studies. So let's discuss our next radiation topic.
Yeah, so this second presentation was from Gustave Roussy from France. They looked at the very interesting population that have germline TP53 mutations that were treated with breast conservation and radiation therapy, and they have long-term data to assess the risk of second malignancy. Definitely, as a radiation therapy, whenever we see those patients with Li-Romani P53 germline mutations, that historically has been a contraindication for radiation therapy. So it looks like they were able to identify between 82 and 2020, 65 patients that have these P53 mutations that were treated with breast conservation. And they looked at 3 outcomes. They looked at in-breast recurrence as outcome 1, contralateral new primary breast cancer, outcome 2, or a non-breast cancer primary tumor, outcome 3. So I'm going to go to the 15 years time point. So you could see that at 15 years, there's about 25% of patients that had of these P53 germline mutation carriers that had either an in-breast recurrence or a contralateral breast cancer event. The alarming number is the non-breast cancer second primary tumor, about 60% of those patients at 15 years. So definitely this is a patient population that is at a very high risk of a new cancer events as germline TP53 mutation carriers. And they have many events that are driven by breast cancer events as well. So I think, for me, at least, this is still a population where I'm extra careful in offering a breast conservation and radiation therapy because of this cumulative risk of having second malignancies. Maybe Dr. Mamounas wants to comment.
Yeah, so the interesting thing here, I think, to me, is that both in breast recurrences and contralateral breast cancers were to some extent of a similar rate. And because the concern there for these patients is that radiation may induce additional cancers. And it doesn't seem to be the case, at least between ipsilateral and contralateral breast. Of course, other non-breast primaries, of course, are high number, as we alluded to, because it's a situation that predisposes to new primaries, but it didn't seem that the radiation had a big detrimental effect. I would think that the ipsilateral recurrence or tumors in the ipsilateral breast would have been significantly higher if the radiation had a detrimental effect. That didn't seem to be the case.
I do agree, and that was one of their conclusions, that potentially some of these patients can be offered breast conservation if they want to. So
just a couple final topics to briefly touch on. We had some new data surrounding endocrine therapies, post CDK4/6 inhibitor in the metastatic hormone receptor positive space, and we know that these patients don't do well on single agent second line endocrine therapy such as fulvestrant. We've seen now a new approval for elacestrant, which is exciting, and we still have alpelisib, which I think we've all struggled with a little bit in the clinic in terms of toxicity. So there's particular interest around a novel agent, capivasertib, which we are expecting an FDA approval later this fall, thus kind of highlighting this here. And so these patients had 2 or fewer prior endocrine lines of therapy, 1 or fewer prior lines of chemotherapy, and could have had prior CDK4/6, but it was not required. And they were randomized to capivasertib plus fulvestrant versus placebo plus fulvestrant. And we're seeing here that most of the patients only had their 1 prior line of therapy, and about 2/3 had prior CDK4/6 inhibitor. We have already seen these data before, that there is progression-free survival benefit with the addition of capivasertib in both the overall and the AKT altered patient populations. So unclear yet which group this FDA approval will come in, whether it's all comers or whether it's those with AKT pathway alterations. What was new at ESMO Breast was an analysis looking at who benefited from capivasertib, and really it was all subgroups, but things like whether or not they had a prior CDK inhibitor, whether or not they have liver metastasis at baseline, whether or not they'd had prior chemotherapy. So again, we're seeing everybody benefiting and anticipating an FDA approval. So I think in that case, it's worthwhile to just go through some of the toxicity, really not seeing the hyperglycemia that we see with alpelisib, since they do work in the same overall pathway. But one big issue here is diarrhea, and there is nausea and rash as well. So look ahead to this coming in the near future. And I want to contrast that a little bit with some updated patient-reported outcomes that we have from the Emerald trial looking at elacestrant in a similar patient population. As a reminder, the Emerald trial was for all comers with metastatic hormone receptor positive, HER2 negative breast cancer who had had 1 to 2 prior lines of endocrine therapy, but it was smart on the part of the investigators for the primary endpoint to include PFS in the ESR1 mutant population, expecting that that was going to be the patients with the most benefit. And that is what we saw. We've already seen these data that those who had at least 12 months on prior CDK4/6 inhibitor tend to be the ones who have the most benefit from elacestrant. And what's new from ESMO was some patient-reported outcome data. We had seen previously that clinician-reported safety data was showing nausea and vomiting, although I think it's interesting that the comparator arm, which is single-agent endocrine therapy, we were seeing 20% nausea, which isn't really what we see in practice. And I would say overall that elacestrant in my clinic has been incredibly well tolerated. And when we looked at patient-reported outcomes, there was really no difference between elacestrant and the standard of care endocrine therapy arm. So I just think it's interesting as we start to think about some of our sequencing options, when we're looking in this post-CDK4/6 inhibitor space. what are we kind of going to reach for as our second line therapy? So Dr. Jones, how do you kind of think through that?
Yeah, just starting with elacestrant because that's our currently FDA approved. I think this definitely gives our patients another option, but I definitely think looking to that slide where, you know, even as San Antonio, where it showed that if you were on CDK4/6 inhibitor for just 6 months or less, you really didn't gain much benefit from elacestrant in the next line. So I'm more thinking of it, patients who have an ESR1 mutation and were able to be on a CDK4/6 inhibitor more than 6 months. And if they don't meet that criteria, I'm going often to Enhertu or Xeloda, because I find that they are often chemo resistant, estrogen endocrine resistant, and that probably not going to buy them much time or any time really with the elacestrant. So I think having elacestrant to use, especially in our patients who were able to, you know, these patients who are meeting this average CDK4/6 usage, 24 months plus, and they have an ESR1 mutation, that elacestrant is a really good option. But I would be very hesitant to use it, and you know, as they kind of divided it on that trial in women who had a shorter time period, specifically that less than 6 month mark on CDK4/6 inhibitor.
When you have someone who has an ESR1 mutation, got more than 12 months out of CDK4/6, and also have a PIK3CA mutation, how are you making decisions there?
Yeah, so, you know, apixaban I don't love because of the side effects, but I've had good success. You know, it really is a good target for the people who have PIK3CA inhibitors. So, you know, elacestrant seems to be very well tolerated. So prior to the, you know, right in the beginning when it was approved, I probably was still going apixaban, but now just how women are doing, I'm considering elacestrant more in my ESR1 mutants. And you can still use apixaban later, right? So that doesn't mean that you can't use that drug as a later partner with fulvestrant. But it is, especially in my diet, especially if I have women who have high risk. So, you know, my diabetic women, African American and Hispanic are also high risk for these side effects. And, you know, I have a patient doing well on it now after progressing on CDK4/6 and then and then AI, and then she was on fulvestrant, and I added, you know, we're on apixaban and she's doing well on it, but she hates she's on Junimet, metformin. You know, she went from an A1C of 5 within 2 months, her A1C was 7.5. So the side effects of apixaban really aren't great. We have a couple of clinical trials, PIK3CA inhibitors that may be better tolerated. So I think definitely I will move more into elacestrant first and then apixaban, but I don't think we should give up on apixaban because it actually, you know, people can have really good responses after, like this woman, my person I'm talking about, was on CDK4/6 inhibitor for 2 years and is now having and she didn't have an ESR1 mutation. I sent Guardant, she didn't have an ESR1 mutation, so we're using apixaban, but she's having a response. She's had reduction in tumor. So even though she hates being on these diabetic medications, so I think elacestrant is really good. It doesn't come with all these side effects and poor tolerance that sometimes can come with apixaban.
Yeah, and you know, I think it's going to become even more challenging once we have capivasertib approved, because then in that situation, you know, we don't know whether one will work after another. I think in my mind, I'm going to want to see what does the toxicity of capivasertib actually look like in the clinic, and maybe that'll help make some of those decisions, because I have not had very good luck with alpelisib in the clinic with, you know, a real world population. We are at time. We didn't have a chance to go over the immunotherapy data, so maybe I'll just give the quick highlight of the Keynote 355 study, because I do think it's important that basically, to get right to the point, in the patients who were on chemo plus pembro, they were, you know, PD-L1 positive on chemo plus pembro and were getting a benefit. They had stable disease or better at 24 weeks, and the chemo was dropped and they were continued on pembro alone. Focusing kind of here on the upper right part of this chart, really the ones who discontinued the chemo and just continued on pembro actually had longer PFS than the overall population. Now, keep in mind, these were responders. We had already selected a group of responders, but both PFS and OS were preserved. So I think in terms of, if the question is, what can we use from ESMO Breast on Monday morning? I think it's that we can feel safe in those who have had at least 24 weeks of stable disease or better, with the combination that we could drop chemotherapy and give a trial of single agent immunotherapy as a maintenance kind of situation. And something else interesting from this analysis was that they found those who had immune-related adverse events, again, focusing on this kind of upper right-hand part of the chart, those who had immune-related adverse events actually did better than the overall population. So kind of similar to what we have seen in other tumor types, where it's actually a good thing efficacy-wise if you have an immune-related adverse event, that you're going to end up actually doing better as a result of that. So I think that's of interest, and again, kind of speaks to some of the biology of immune checkpoint inhibitors. I know we are already over time, but just in the last couple minutes, would anybody like to throw out a statement about a trial that they thought was particularly interesting at ESMO Breast that we have not yet covered here tonight? All right. Well, I think then we are all set. It was a pleasure to speak with all of you tonight. Thank you for a robust conversation, and thank you to Total Health Conferencing and all of our attendees.